Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sonogenetics. Sonogenetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate datasets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you are a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Welcome, everyone, to the Genetics Podcast. I'm super excited to be here today with Raghib Ali, who's the CEO and the CMO of Our Future Health, which is partnered with the NHS in the UK to do genetic testing of 5 million adults to identify new methods for early detection and diagnosis for disease. Obviously, genomics is a big part of this. I know you're also thinking about other kinds of omics over time, so we'll talk through that. But you recently crossed a major milestone of 1 million participants with biobank blood. I think there's a Nature Medicine paper as well that we'll link to that people can read. And it feels like this has come in record time, which is amazing. We'll talk a little bit about that. And I'm curious of how you all managed to accomplish this just in a couple of years. But people who've listened to the podcast know a lot about UK Biobank, all of us, FinGen. They also know a lot about Our Future Health, probably because I talk about how cool it is all the time. But I'm excited to have this conversation here today with you who've been there since the very beginning. So thank you, Raghib, for joining me.
Great to be with you. Thanks for inviting me.
So for people who aren't familiar with OFH, can you talk a little bit about its focus? Why did the program start? And what are you all trying to achieve?
Sure. I mean, Our Future Health was this kind of the idea for it came about around 2017, 18, when the Sir John Bell, who was the Regius Professor of Medicine at Oxford at the time, also the UK Government Life Sciences Champion, and others were thinking ahead as to what would be most useful, both from a kind of health point of view, but also from a life sciences industry point of view, in terms of a resource that could really help us to move towards a new model of healthcare. So our current model of healthcare is very much based on treatment of late-stage disease. So when people develop symptoms and signs of disease, and my own background, which we might come back to. I mean, I trained as a doctor in what's called acute medicine, so working in A&E or the emergency department, and seeing patients, with heart attacks, with strokes, with cancers that had already spread, advanced dementia, renal failure, etc. And these diseases, of course, had developed over many decades, but we just see the very end of, and that's obviously bad for patients. It's also bad for the healthcare system. So one of the main drivers behind setting up Our Future Health was to say, can we have a different approach to healthcare, which is to say we can identify people at high risk much earlier in the natural history of disease, and predict their risk, inform them of that risk, and then through both pharmacological and non-pharmacological means, give them the opportunity to change that risk over time and ideally catch them as early as possible. So it's a study very much focused on early detection, early intervention, prediction, and prevention of all common chronic diseases. And as you say in your introduction, it's 5 million people, which when I first heard that, I thought was slightly crazy. Certainly very ambitious. But of course, for a prevention study, you do need large numbers because you are trying to identify people who are at high risk, even those at the high risk for particularly cancers. You need millions of people who are at risk in order to have enough people developing those diseases over a reasonable period of time to establish that evidence base, within the next 5 to 10 years, hopefully.
What are some of the diseases where you think we're going to see like at scale impact first? Some of the things that people think about are hereditary cancers, Alzheimer's, we've got cardiometabolic diseases. You have both an opportunity to challenge with such a broad platform, right? Where are you thinking that the impacts are going to come first?
So almost every common chronic disease is a combination of genetic susceptibility, lifestyle, risk factors, and environmental risk factors. So the purpose of Our Future Health is really to look at most of the common chronic diseases which have the largest kind of impact in terms of morbidity and mortality, not just in the UK, but to be honest, across all high and middle income countries and to an extent now globally. So starting with the obvious kind of high burden diseases, so cardiovascular disease, of course, diabetes, some of the more common cancers. These are the diseases, and again, we understand them much better than many diseases. We know we have a good idea of what the relative importance of genetics, lifestyle, and environment is. But at the same time, if you look at our current screening programs, they're very much based on age. So you reach 40 and you're offered screening, for example, for diabetes and heart disease in the UK or in England. When you reach 50, you're offered screening for breast cancer and colorectal cancer. But there are people who are younger than those ages who are high risk through a combination of genetic susceptibility, high risk, but also because of their lifestyle and environment. And it would make much more sense to use risk stratified screening programs where you screen people based on the actual risk, not just age. Of course, age is always going to be one of the most, if not the most important risk factor, but it's not the only one. So that's one angle in terms of which disease we look at. Second is where we just don't have good data yet on both etiology or risk factors and which interventions can be run. So you take a disease like pancreatic cancer. It's not very common, but it has a very high mortality. And we don't really know what the important risk factors are for it. And we certainly don't know how to intervene early to prevent it. So our future will be the first study that's large enough to really look at a disease like pancreatic cancer, which is, I think it's number 10 or 11 in the list of mortality, even though it's, I think the incidence is something like 17 per 100,000. Yeah, so it's a relatively less common disease, but it has a very high mortality.
Wow. The closeness to the healthcare system here is both an amazing asset, but it has probably brought some of these issues in sharp contrast of, as we start to you plan to return results to participants, those are going to hit the UK healthcare system. And so there's a great design here because you're going to be able to learn quickly actually what is the real world impact of this versus, say, the UK Biobank that has no recontact, and you can look at observational data but not actually impact on the health system. Are there any stories that you can share about how you've managed to work through this with the NHS? Because I suspect there are a lot of concerns around, are we going to result in an influx of people that have a higher risk, but is the pathway ready to handle this? Because you're coming at this at a scale that no health system really has seen before, right?
Yeah, that's a very important question. And as you say, excuse me, particularly for our international listeners, the NHS has some unique opportunities because it's a single healthcare system. It's the largest single healthcare system covering nearly 17 million people across the UK. But it also has challenges in terms of waiting lists, difficulty of accessing general practice or primary care, emergency care, etc. And so we are very conscious of any research study, or particularly one on the scale of our future health, how we manage any potential impact on existing healthcare systems. Of course, a priority is always going to be on treating people in need now. But we also need to think ahead. And the NHS understands that as well. The government understands it. And to an extent, industry understands it as well, that we need to start thinking ahead because our current healthcare system is neither good for patients nor for the system as well. It's taking up a huge amount of resources. As if people are not getting the best outcomes because we're catching diseases late. So it's trying to get that balance right. We will work closely, and we are working closely with the NHS. So for a particular disease, if we take the example of diabetes and cardiovascular disease, where there is an existing health check program in England, it would be relatively straightforward to run a study within our future health to see whether adding genetic susceptibility through a polygenic risk score to an existing risk score, so what we call an integrated risk score, will both lead to better clinical outcomes, but is also cost effective. Similarly, for breast cancer, where there's an existing screening program on colorectal cancer, that would be relatively straightforward, and we would do it in close coordination with the existing NHS programs. For new areas like prostate cancer, where it's a very common cancer, of course, the most common cancer in men, we don't have great understanding of the relative importance of genetics, environment, and lifestyle on prostate cancer. But there are some existing screening programs, not so much in the UK, but in the US, they tend to use PSA and to an extent MRI as well now, where we would be looking to establish a new kind of evidence base for this approach to identifying people at the highest combined risk based on the risk factors we know, but also identifying new risk factors. And one of the other important points about future health is that it's much more ethnically diverse than any previous UK study. So we have much higher numbers of people from ethnic minorities, from more deprived populations, from every part of the UK, and crucially from younger populations as well, because of course most of these diseases start to develop in early or middle age. Early adult, middle age. And if you start later, then of course you miss those opportunities to both understand the risk factors, but also to intervene early. This is a good segue, I think, onto the recruitment question. Like I said earlier, I think you've broken some land speed records on getting to 1 million people. You've also done so while recruiting, like you said, an extremely diverse cohort. Can you share any learnings from that for other people who are working on these kind of programs about what's worked to get you here so fast? Sure. So as I said at the beginning, the idea of the program came around in 2018. The funding was announced in 2019. Our Future Health was set up as a charity and a company in April 2020. I didn't join right at the beginning actually because of the pandemic. So I was kind of busy both in hospital and with the vaccine rollout and various other duties advising government on the epidemiology of COVID. But so I joined exactly 3 years ago, actually, January 2022, part-time, just after the Omicron wave. And one of my main responsibilities, I joined as Chief Medical Officer, but I'd worked on studies like UK Biobank before. I'd set up my own study in the UAE, a small cohort study, or relatively, didn't feel that small at the time. It was going to be 20,000 people, but everything feels relatively small now compared to our future health. But my main task when I joined was to put together a recruitment strategy, how we could recruit this unprecedented number of people, both faster than any previous study, but also at lower cost.
Pressure.
No pressure, exactly. So yeah, from January 22 until July 22, we kind of spent 6 months putting the plan together. And we had a couple of important learnings from previous studies. So UK Biobank, which I said I'd worked on initially many years ago, it had already established the use of non-NHS sites. So, for example, shopping centres to recruit participants. The NHS Gallery trial, for example, had used mobile units in supermarkets to recruit participants. And the thing that we added to that, so we used both of those methods, but the thing that we added to that, which I'd really learned from the vaccine rollout during COVID, was the use of community pharmacy. And people were somewhat skeptical as to whether that would work because no one had taken blood through community pharmacy before. But I was confident enough to at least run a pilot and then to extend that. So in October 2022, after running a small pilot through pharmacy, we launched recruitment through a relatively small number of sites at the beginning. So we started with, I think, about 10 sites. But so it's a combination of those three things, which are all outside of the traditional kind of NHS system, but they're easier for participants to access.
Yeah.
So one of the key things we wanted was to make everyone who we invited to take part to be able to attend their clinical appointment within a 5-mile radius of where they lived. And so over the last 2.5 years, or nearly 2.5 years now, we have provided through a combination of shopping centres, mobile units, and pharmacy around 400 venues for people to attend across now the whole of Great Britain. So England, Wales, and and Scotland. Northern Ireland will start later this year. But this is a UK-wide programme, and it will include Northern Ireland as well. So, as you say, we have had an unprecedented response from the British people. The first step is to consent online. And actually, as of today, nearly 2.2 million people have consented.
Wow.
You fill in the questionnaire online, and we have 1.6 million people who complete the questionnaire. And then you do attend an appointment to have some basic physical measurements taken and give you a blood sample. And we're approaching 1.3 million blood samples now as well. And
I see you looking at the side. Do you have a dashboard that lights up in real time?
Exactly. So we check that daily. And I mean, it is completely unprecedented. I mean, last year, we saw 700,000 people in our clinics.
Wow.
Which has never been done before by any program, neither in the UK nor globally. There are other programs, as you know, in the US, particularly the All of Us program, which has similar aims and objectives, and in some ways is ahead of us in terms of providing feedback to participants, whole genome sequencing, etc. But in terms of recruitment, I think we recruited more participants last year than the programs recruited over the last 6 years. So yeah, we had a very successful model.
Why do you think that is? I've been obviously following and used the data from All of Us since they've opened it up a little bit more widely. What do you think that program can learn from OFH and vice versa?
But of course, the US system is different and the population is different. And what they have been very successful at is to recruit a much more diverse cohort, particularly in terms of ethnicity, but also other aspects of diversity in the US context. And that was a deliberate and very important strategy for them. We have not gone as far. So of our 2 million people, roughly 10 that have consented, roughly 10% are from underrepresented groups. So around 200,000 from ethnic minorities, around 200,000 from the most deprived quintile, and around 400,000 actually from younger age groups, so below 40. So we have followed different approaches. We've provided many opportunities for people to join. We've tried to make it as easy as possible, basically. And to your question earlier about how we've done better on diversity, we've placed clinics in areas of higher deprivation, higher ethnic diversity, and younger age groups for much longer than in other areas. We provided reimbursement to participants so that no one was excluded for financial reasons. Particularly through the use of mobile units, we've gone to places where no one has gone previously to make it easy for people to access. And that's really the biggest factor, probably, is having that number of venues. I mean, UK Biobank, for example, used 22 venues to get to their 500,000. So we've already used 400 sites now to get to 1.3 million.
Right. I mean, one of the principles of recruitment, especially at this scale, is you've got to lower the barrier to access as much as possible. You've also got to present enough value for the marginal participant. The first couple 100,000 do it because they're nerds like me and they just want to be part of it. But by the time you get to 1 million people, you're far out of the genetics podcast listener cohort. What have you learned about what brings participants to this and gets them to actually break out of their routine and go to Boots and get their blood drawn and be part of it?
One of the other things we did early on, even before I joined, is quite a lot of work with the public and to understand, members of the public, to understand the motivators to take part in this kind of research. And the program itself is somewhat unique in that it does give people the opportunity to receive information about their own risk of disease. So based on both the early work we did, but also we collected a lot of data from our own participants now and from continuing from the public, roughly 80% of people join because they want to help improve people's health in general. And so mainly altruistic, and 80% are also interested in their risk of disease. So giving people the opportunity to find out about their risk of disease is definitely a major draw. So they're the two biggest kind of factors. And as you say, that has meant that we've moved beyond the kind of worried well. So when we look at the kind of baseline characteristics of our cohort, broadly speaking, I mean, there'll always be a slight kind of healthy volunteer bias in any type of study like this because people who are very sick just can't join. But broadly speaking, what we're finding in terms of prevalence of various risk factors and diseases in our population, it's not much lower than what you'd find in the general population from, representative samples like the Health Survey for England. So that's encouraging because, of course, we don't want it to be just a worried well cohort because that will obviously be a missed opportunity and potentially increase inequalities.
How do you think about the choice between arrays, whole genome, exome sequencing? I think you made the choice to initially start with arrays. You've got banked samples, but the UK has also made a big bet on whole genome sequencing through the Genomic Medicine Service. And I'm curious how you think about the way you'll move up that technology stack over time, or whether actually the broad polygenic risk scores using arrays or low pass sequencing is something that you may just push indefinitely to 5 million and beyond.
The advantage of having 5 million people, as I said earlier, is we can look at many more diseases. The disadvantage is that any test that you do on 5 million people is extremely expensive.
Yeah.
So genotyping is still significantly cheaper than whole genome sequencing, although of course costs are coming down and that gap will decrease over time. For something like a polygenic risk score, whether you have genotype arrays or whole genome sequencing, it doesn't make that much difference. So it does really depend on what the research question is. I mean, the slight caveat to that is that we don't have as much data on non-European ancestry populations. And so the genotype arrays are not as well suited to populations. And in the UK context, we have a lot of people of South Asian origin, quite a lot now of African origin and other ethnic groups as well. And the arrays, although they're better than they were 10 years ago in representing those populations, because there's a lot more data out there, they're still certainly not as good as they are for European ancestry populations. And so it is, I think, looking ahead, and probably not that far ahead now that we, as you said, we know that this project is going to be around for forever. So it's an opportunity to really maximize the benefits from it. And if we're interested, particularly in mechanism, in the underlying biology of disease, drug discovery, etc., and all the uses where whole genome sequencing is better than genotype arrays, I'm fairly confident now that at some point, over the next 5 to 10 years, all of our participants will also have their whole genome sequenced, and then we can come back to other omics. But yeah, that's like, and as I said, the cost is coming down as well. So there won't cost as much. Like UK Biobank, of course, went through kind of 3 phases. So genotype, then exome, then whole genomes. That was partly based on cost coming down over time. We would be in a position just to go straight to whole genomes soon, particularly for non-European ancestry populations. That would be a priority.
You have also, similar to UK Biobank, pursued a public-private partnership strategy where there's pretty deep collaboration with the pharma consortium and other nonprofit partners. I'm curious what you learned from this. This is something that I don't think all of us in the US has done, right? It's purely federal funding. Most of the UK programs have gone, very public-private partnership driven, resulting in less cost for the government overall, and probably a little deeper engagement, certainly with industry around what they want and need. There's probably trade-offs there on what that allows you to do at a healthcare system level. But I'm just curious about what you've learned from that, because getting 10 people to agree on anything, much less 10 Fortune 500 companies or Fortune 5,000 companies to agree on anything is another beast entirely.
Yeah, no, it has been. I mean, Our Future Health, I should have said at the beginning, was set up deliberately set up as a public-private partnership. So because it came out of the life sciences industrial strategy, from the beginning, it was intended to be kind of matched funding between government and industry. So in fact, the initial funding from government was only 79 million, and 160 million had to be raised from a combination of pharmaceutical industry and diagnostics. And the list of companies that work with us is on our website for those who are interested. As you say, they are most of the large pharma companies and diagnostic companies globally. Since then, the government has put in more money, so it's approaching now sort of 50-50. That is helpful, as you say, partly because it saves government money. And we've spent around 300 million pounds so far on the program to get to where we are, which is much lower cost than any equivalent study like it. But the main advantage of this public-private partnership is not so much the financial one, but it's really the scientific opportunity that will be realized and the public health benefits that we realize through that collaboration. We work in this field. We know that nearly all medicines that people are using today have come about through collaboration between academia, industry, and health systems. And to have that from the beginning, I think, enables us to realize those opportunities much faster than other programs. And also, our industry partners are not just using the resource, they're helping us to design studies. And it's a kind of co-design process on the scientific protocol and the next stage. So particularly when we start to run what we call recontact studies and clinical trials based on on our participants, based particularly, for example, on recall by genotype type studies which haven't been done before, and also prevention in general has been somewhat for various reasons over time. But even industry, as they can see that the current model of healthcare spending is not sustainable, and they want to move towards research which focuses on prevention, early detection, early intervention. So overall, I would say our experience has been very positive. You're right, it's not easy working with 16 companies to come to decisions, but it hasn't been as challenging as many people may think. And we're all very much aligned on what we're trying to achieve through this program. Having that initial basis for joining has really helped us to get to where we are. It is a lot of credit goes to that. I should also mention we have the medical charities that have joined us. So Cancer Research UK, British Heart Foundation, LifeArc, Casper Lung UK, and others will be coming, and many affiliate charities. So that kind of combination of government, NHS, industry, medical charities, that's really been instrumental to our success today.
Yeah, amazing. I'm curious to hear a little bit about medical records. People think about the UK and they think about an integrated national health system, and to some degrees that's true, but you working with it day in and day out have ran into cases where it's not true, right? We know that GPs aren't as linked up as we like them to be. There are lots of issues, but nonetheless, you have an opportunity to build the world's biggest linked genetic and medical record data set, which is super powerful for a variety of reasons. What have you learned about that? What can you see in the medical records, and what's really nicely linked up and easy to make sense of, and where is there still work to do in terms of really having like a national scale platform that you can think about plugging into?
The NHS in the UK actually does provide a unique opportunity globally. So although some of the Scandinavian countries have similar systems, of course their populations are much smaller and less ethnically diverse. The US has a much bigger population, but it's a very fragmented system. And so it's really impossible to have that single healthcare record. I mean, in the UK, there are some things which are very well recorded and almost kind of cradle to grave. You have information, particularly for anything in hospital and for death, cancer, certain other diseases. There are very good registries. Where we have had less success to date is on the primary care data, being able to link to that, although that will change. So the Secretary of State late last year announced that there will be a new directive from him and from the Department of Health to ensure that for consented cohorts like Our Future Health, UK Biobank, Genomics England, participants have given explicit consent to link to their health records. And so that data should be used, because a lot of data, of course, many diseases aren't managed in secondary care and hospitals. They're managed in primary care by general practitioners. If you don't have access to their data, then we'll never know whether people develop those diseases. And even to an extent, some of the risk factor information where those things are measured, like blood glucose, cholesterol, blood pressure, etc., which are routinely measured in primary care, wouldn't necessarily make it into the secondary care record. So GPs rightly were worried about some of the issues on patient confidentiality and also reliability that they might have for how the data is used. So there's work going on within NHS England to resolve those two issues. And over the next few months, I'm confident that we will be able to apply to access the primary care data as well. And that really will be a game changer in terms of what we can do with these large consented cohorts. There's nothing else like it really in the world. Having said that, there is still some information that you won't find in the healthcare record. And that's why we are collecting blood samples to have a look at genetic data. But the questionnaire that we collect also has a lot of information, particularly on risk factors. So the routine data may not even have information about people's smoking status, for example, alcohol use, physical activity, etc., which are all important risk factors which we need to collect separately. And then there are environmental exposures, which again are not necessarily going to be recorded in the health record, but are equally important. Wider social determinants of health, income, employment, education, etc. So we're trying to, getting back right to the beginning, to identify someone at high risk of the disease, you really need information on all the relevant risk factors, many of which are outside of the health system. And our future provides the opportunity really for the first time to get a comprehensive picture and identify it as a high risk, and then offer them the opportunity for interventions that will reduce their risk and enable them to stay healthier for longer.
How are you all thinking about other omics? We had an announcement recently from UK Biobank that they're scaling up the proteomics work they're doing with Olink. There's lots of directions you could take it. I'm curious how you're thinking about that, and also sequencing it. I imagine the challenge you have is it's gonna take years to push to 5 million people, but in parallel with that, you're also gonna have people wanting to start thinking about sub studies and recontact by genotype and MRIs and all sorts of things that we've seen happen in UK Biobank right over in waves over the year. I'm curious to hear what you've learned from all the impact that that's had and how you're thinking about applying it in the unique platform that you have.
Yes, maybe I'll make a slightly broader point and then come back to that. But when you're trying to recruit 5 million people, what has traditionally happened with cohort studies is that you complete recruitment and then you start providing data to researchers. And that's been a standard model, including for UK Biobank. Because our cohort is so large, we thought if we wait, another 3 or 4 years to get to 5 million, that would be a missed opportunity.
Yeah.
And so even last year, we already provided quite a lot of data to researchers in our trusted research environment in Arteria. And as of today, there are over, I think, 1.4 million questionnaires, 1.1 million linked NHS data, and 650,000 genotypes in Arteria, and also clinical measurements on about 1 million people. There's already an extremely large resource available to researchers. That's an important point there for our listeners who are interested in accessing the resource, particularly those from academia, NHS, or other health systems, small and medium enterprises, companies. They should go to our researcher website and look at the opportunities to access data now. In parallel, we do also want to enhance the resource. So we've talked a bit about sequencing, and I think that will happen in the coming years. Proteomics, of course, in some of the early data from the first biobank study was very encouraging in terms of how that's also has in potentially even more value than some of the genetic data in prediction of disease and particular diseases, and providing an additional kind of biomarker signature for identifying people at high risk. So that is certainly on our agenda as well and on our horizon. And my expectation is that that work again will start. So sequencing plus proteomics plus potentially other omics plus digital biomarkers plus dietary data, environmental exposures, linking to administrative databases. All of this will happen in parallel over the next 2 to 3 years. So that if we assume we can get to 5 million participants by 2028, 29, in parallel, we'll start to enhance the resource for the first, 1.5, 2 million people on the more kind of biological omics, but also for the whole cohort and all the other biomarkers that we can measure either through mainly through online methods. So there's primarily digital cohort to make it as easy as possible to collect additional data.
I'm curious actually to take like a few steps back as we close out here and talk a little bit about your background, because it struck me that you have obviously initially trained as a doctor focused in acute medicine. You've also done further degrees in public health and epidemiology. You mentioned before we started recording that you don't have a genetics degree. You probably have a genetics degree de facto now for sure, but in some ways I think it's actually really helpful because genetics people can get so focused on genetics as you see a nail and you've got a hammer, but with your perspective, you can look at genetics and you can say something like proteomics might be more useful, which someone who's been in genetics for 20 years very, very struggles to say, even if the data is screaming at them. So I'm curious to hear your story about how you actually got into this and how that brings a unique perspective to this.
Sure. No, I mean, my journey has been somewhat unusual as to where I am today. So when I graduated, I mean, I went to Cambridge, which had quite a strong focus on basic science in the first, certainly in the pre-medical or the first 3 years. And genetics was part of that, but also, I mean, this is 25 years ago, so obviously the fields, and we've done a lot since then. But I would say for most of the early part of my career, I was very much focused on my clinical training. And I did enjoy acute medicine and treating part, but diagnosing, managing, and treating patients. But at the same time, quite early on in my career, I realized that we are failing most of our patients because we're seeing them too late. And it was really through a combination of public health epidemiology approaches that would be able to identify those people at high, well, both to understand the risk factors and understand how to better prevent disease. So quite early on, I made a decision not to go fully into public health and epidemiology, which I could have done, but I didn't want to give up clinical medicine, but to start studying it kind of academically. So from 2000 to 2004, I was mainly doing clinical work, and then 2004 to 2009, I was doing both my clinical training, but also training in epidemiology, clinical trials as well, actually clinical pharmacology. So at this point, I'd moved to Oxford as a clinical lecturer in clinical pharmacology. But that enabled me to cover quite a broad range of topics. I worked on UK Biobank only for about 6 months, but even that 6 months was very helpful to understand how these large prospective cohort studies are set up. And some of your listeners may be familiar with Sir Richard Doll, who was one of the most famous epidemiologists ever, actually, because he really established the link between smoking and lung cancer. And I met him quite towards the end of his life, but he was certainly an inspiration for me in terms of what I did next, which was he suggested to me to set up a prospective cohort study in the Middle East because, or in Arab populations, because we had so little data from those populations. And so after I completed my clinical training, I actually spent 7 years in the UAE. I set up the first prospective cohort study there called the UAE Healthy Future Study. That was in 2011 to 2018. Then I moved back to the UK, although that study is continuing in the UAE. And as I said, I would have started on our future health if it were not for the pandemic. But I think to come back to your question about the relative importance of genetics and genomics, I think what's helped me is having that much broader perspective. So understanding that for most people and most diseases, genetics is an important component, but generally not the most important component, and it's one of many factors. And if you only look at genomics, you're going to miss a lot of important information about risk factor. There are some resources out there which don't have, they have the genetic data, but they don't really have anything else.
Yeah.
And they're always going to be somewhat limited in being able to. And data is not deterministic either for most diseases. It gives you a range of probabilities really as to what your risk is. But what we have within our future health uniquely is that combination of risk factors. And in the UK, I think in the US, you have slightly different terminology, but we say that postcode is more important than genetic code, or maybe his zip code is more important. Yeah. In terms of your likely kind of life expectancy and health life expectancy, it's still the case that where you are born, grow up, the kind of socioeconomic circumstances, educational, employment, etc., are certainly much more important for most of these than genomics. But these are not either ors. We need to look at both. And because genetics has particularly genotyping, but even whole genome sequencing, cost is already very low, will become even lower. It will be very low cost to measure people's genetic risk of disease for maybe 30, 40 different diseases for the cost of even a cholesterol test. It's really very low now.
Yeah, I think that's right. The time invariant nature of it is useful as well, right? You only have to do it once. You might have to measure cholesterol pretty regularly to get a sense of what's going on. What did you learn from the study in the UAE that you set up? I'm curious to learn a little bit more about that.
So one of the reasons we're interested in populations in the Gulf is they have some of the highest rates of diabetes in the world. So by the age of 50, about 50% of people have diabetes.
Wow.
And the levels of obesity, physical inactivity, unhealthy diet are not that different, although we don't have as good data based on what we have seen. They're not that different to the US. And so it seems there are additional factors which are driving that increased risk. And in fact, it's not just the Gulf countries now. We're seeing that even in poorer countries in the region. So if you look at Egypt, Sudan, Lebanon, they also have very high rates of diabetes. If you look eastwards towards Pakistan, India, Bangladesh, again, very high rates of diabetes, where it's not just because these are very high income countries. So what we don't know well yet is what's really driving that. So of course, it could be genetic, and there is some data now. In fact, there's quite a lot of data now, which suggests that genetic differences are not the most important component here in terms of explaining that difference. Although in the UAE context, it might be slightly different because they have high levels of consanguinity and endogamy, which they may have accumulated some rare mutations which are increasing the risk. But I think what's more likely to be driving this is epigenetic kind of factors. So what's common to quite a lot of these populations is that they have had within the last 3 generations relative food scarcity, and that would have led to
Oh,
higher
interesting.
propensity to store energy. So we saw that in the Dutch kind of famine in Europe, and where there's much better data. If you look
Yeah.
at the UAE or Bengal, for example, where there's a Bengal famine in the 1940s, even in the UAE, although it's a very rich country today, it was very, pre-oil, it was very poor. And in the 40s, again, there was relative food scarcity. So I think that's driving some of it. So it's a combination of genetics, of course, is going to be part of it, epigenetics, and also that very rapid change in people's diets and change from a high physical activity, healthy diet to low expectancy, unhealthy diet over a short period of time.
That the epigenetics point is a really interesting one. I understand that it's been established very clearly in C. elegans, this intergenerational epigenetic inheritance, right? Where it's like we're going back to Lamarck, right? Or the what happens to the parents doesn't get passed on in the genetics, but actually is imprinted in a way in the epigenetics, and that's passed on. I wasn't sure if this had been really established. I knew that there was some very controversial work around the Dutch famine, but has there been more work that's started to show that this might be the case in humans?
So, as you say, it's been well established. I do remember Lamarckism from my undergraduate days and how we somewhat were dismissive of it. And of course, it's not true for the genetic part, but for epigenetics, it wasn't even a field when I was at university. But there is evidence. I'm not a specialist in this area, but from the papers that I've seen, particularly if you look at some of John Chambers' work from Imperial and in Singapore, he's done quite a lot of work on the epigenetics of diabetes in South Asian populations. And the data that I've seen from his research shows that it's an important explanatory factor for why South Asians are at higher risk of diabetes and to an extent cardiovascular disease than European ancestry populations. So yeah, that's the work I'm most familiar with. But I think
Fascinating. I'll be
yeah,
emailing.
exactly.
See if I can speak to him. Very cool. Yeah, it's one of the that is it's a really I mean it has incredible implications if that's the case, right? And it opens up a whole new set of questions of how you go about addressing that.
Exactly. Yeah, just coming back to our future health, because having a multi-ethnic population in the same country, with the same methods of measuring both risk factors and outcomes is very unusual. In fact, it's not really been
Yeah.
possible before. Because when you're trying to disentangle genetics, epigenetics, environment for these complex chronic diseases, it's even more complicated if people in different countries with different exposures and different health systems. So our future health really provides the first opportunity ever, I would say, for not just diabetes, but many of the common diseases where to much better understand the relative importance of these risk factors across ethnic groups.
Yeah, that's right. Because you need the scale to get that, right? Otherwise, you're gonna die from the multiple hypothesis testing that you do with all the different
Exactly.
all the different factors, right? There's something else that I know you've mentioned before, which is despite the incredible contributions you've made to science and all the progress you've made professionally, going to Cambridge back in the day and all the work you've done, you didn't start in life with the most obvious path to where you are today. You had, I think your father had health problems when you were very young that resulted in a lot of financial insecurity. I think it would be really great to just hear about that if you're comfortable talking about it, because not everybody who's listening to this necessarily might have the confidence that they can do the things that they want to do in life based on the circumstances they're starting with right now. So I think it's really helpful to hear from someone who's accomplished so much despite not starting a leg up, if you're happy to share that story.
Yeah, no, thank you. So, I mean, my father was trained, he was from India. He came to the UK in the 60s to study and trained as an accountant. But unfortunately, he developed glaucoma very early in his 30s. And when I was 5 years old, he'd already got fairly advanced glaucoma. He just couldn't work anymore after that.
No.
So basically, we had no income really my mom started to work, but that was very difficult for kind of the family from the age of kind of 5 to when I went to university. And also the area where we lived, the school that I went to was really one of the worst. We didn't know at the time. You just went to a local school, but it was one of the most poorly performing schools in the country. So with that kind of starting point, the chances of going to university, becoming a doctor, etc., were basically zero. And in the area where I lived, it was very unusual to go to university. But we were very fortunate that the government at that time had a scholarship scheme for children from deprived backgrounds to get to a better school, so a local private school. If you passed the exam, which I did, and I was very fortunate, good backing in terms of my parents always encouraging us to study, despite the difficulties that we were facing. And it was going to that better school, although it wasn't great academically, but it allowed the opportunity for those who wanted to study and were able to do well to get. I mean, I applied to Cambridge for medicine and unfortunately got in. But I remember reading a statistic, which is that I think out of 3,000 students at Cambridge in my year, I think there were only 2 who had come from free school meals. Like, this is a marker in the UK, if you're frank, from a background from it. And for medicine, it's extremely uncommon at that point. So I'm very grateful that I had the opportunity to go into Cambridge. Obviously opened up. I did feel very much out of place for the first few months, but I settled in quite quickly, and that really opened up many horizons and ambitions for me, seeing very famous scientists, Nobel Prize winners, etc. And then when I moved to Oxford, similarly, again, having those kind of role models. But it's true, there are not many role models, certainly when I was starting, either from ethnic minorities or from more deprived populations. And there are more now, and I hope, particularly for some of our younger listeners who may be thinking that they can't get to the top of their respective fields, that at least in the UK, and I'm sure this is true in many other countries in the US, if you work hard, aim high, be ambitious, there are opportunities to do that. And I hope that will encourage people to do that as well.
Yeah, talent is very widely distributed, but opportunity is very often not. So I really appreciate you sharing that, because I think there are certainly people listening who will benefit from having heard that. Well, Raghib, this is amazing. Congratulations to you and the whole team for all the progress here. If people want to join, I know they can visit your website if they're in the UK. Of course, ourfuturehealth.org.uk. Is there anything else that you're looking for? You hiring? You're looking for collaborators? I know you said researchers can go check
we're always,
as well.
Well, firstly, of course, we're always keen for people to join the program. So
Yes.
Thanks for sharing the website. As I said earlier, for researchers listening, we're very keen for you to use the resource. The whole point of setting this up is that it's used by as many people as possible to maximize the benefits from it. We are still hiring, particularly as we're moving towards the next stage of the program, which is to start providing feedback to participants and to run recontact studies and clinical trials with our participants. That's going to be an important focus for the coming years. And finally, on collaboration, I'm always open to ideas. I think one of the most important benefits of UK Biobank was setting the precedent of an open access resource and to really drive collaboration internationally for a single resource. We want to have something similar at Our Future Health. So if people have many more ideas outside of Your Future Health and inside Our Future Health, so please do get in contact if you'd like to share any of those ideas with us.
Amazing. Well, thank you again. And thanks everybody for listening. We'll see you next time.
Thank you.
That wraps up this week's episode of the Genetics Podcast. I'd like to give a huge thank you to our guests for sharing their valuable insights and experience. And thank you as well to our listeners, as always, for tuning in. If you enjoyed today's talk, the number one thing I would really appreciate from you is if you could share it with a friend or colleague who you think would enjoy it as well. We would also really appreciate if you could subscribe to our show and give us a quick rate and review on Apple Podcasts, Spotify, or your favorite podcast platform. Both of these things help us become more visible when people search for genetics and precision medicine podcasts. And we're always eager to hear from you. Please reach out to us with any questions or feedback on social media. You can find Cynogenetics on Twitter, LinkedIn, or visit cynogenetics.com. Finally, a big thank you to the team behind the scenes who make all this possible. In particular, Amy Cousins and Sonia Shah, who produced the show, and James Pierce from Selected Frequencies, who handles the audio engineering. I'm Patrick Short, your host, and it's been a pleasure. Thank you, and we'll see you next time on the Genetics Podcast.